Okay, hello. Today we'll be discussing hypertensive retinopathy. So we've previously discussed the diabetic retinopathy, and both are very common diseases affecting the eye. So, what does the eye tell us about the body's blood pressure, and are they even related? So the answer is yes. So just by looking at this picture, you can tell that there's definitely a lot going on. We don't have a clear view of the retina, and you've heard that the retina has both vessels, venules, and arterioles, okay? So will changes in the arterioles caused by hypertension appear in the retina? And yes, the answer is yes, they will. So the eye, you can think of it as a window to the vascular system of our body. So yes, they do have a relation. So we'll go through the pathophysiology. We have a grading system, which we will discuss, and we'll see key points and discuss if there's any symptoms or clinical picture of the patient. So let's get started off with the grades. So we have 4 grades of the hypertensive retinopathy. So this classification is formed by 3 people. It's Keith, Wagner, Barker. Okay, KWB, I'm sorry if the spelling is a bit off. We have grade 1 and 2 and grades 3 and 4. So grade 1 and 2 are milder and more chronic, and grades 3 and 4 are more severe and rapidly occurring, okay? You'll get a better idea in a second. And keep in mind, I'm saying grade 1 and 2, this is a classification, okay? It's not related to grade 1 hypertension, although they do have a relation, but they are different classification, okay? Now these classification are based on what we see in the retina, and we correlate it to the hypertension, to the blood pressure of the patient, okay? So, grade 1, what do we see? So, if you don't have an idea of what the basic fundus or examination of the eye looks like, you can check out our first episode. So, if you compare it to this picture, actually, like, you can tell a lot of things are going on, okay? So, this is grade 1 hypertensive retinopathy. So, what's happening? We have narrowing of the arterioles now. This part over here, the thick one, okay, this is the venule. So we're not looking at it. I'm looking at the artery, which is smaller, okay, and it seems transparent, okay, but keep that in mind. So the arteries are transparent, and that's why they appear red, because they show the blood that's flowing inside of them, okay? So with increase in the blood pressure, we'll talk about the pathophysiology. The arterioles begin to constrict in comparison to the venules. So the normal ratio of artery to vein, and I'll show you in a second. Let's go on. The normal ratio, let's get started, is 2 to 3. Okay, so this ratio begins to decrease because the arteriole itself is narrowed. So it's called the arteriovenous ratio, okay? So what's the process? Why does the arteriole narrow, okay? You may have thought the opposite, so the blood pressure elevates and the arterioles dilate, okay, because increased blood pressure. So what's happening? So let's get started by talking about the normal body vessels. So the normal body vessels have a sympathetic innervation, and they have a mechanism called autoregulation. So whenever there is an increase in the blood pressure, there is sympathetic tone going to the arterioles, which cause them to constrict, in addition to the autoregulation. Now the retinal vessels, they lack the sympathetic innervation, okay? And they require on the autoregulation only. So when the blood pressure increases, the arterioles begin to narrow, and this narrowing is very small. And if you look at the picture, like, you can barely notice that there is any difference, okay? So you may ask yourself, so why are the arterioles narrowing? Now, first of all, the capillaries are very delicate, okay? And we want to protect them. Like, we don't want this high blood pressure to cause damage to the underlying capillaries that we have. And the retina is a very delicate tissue, yeah? So it doesn't need this large amount of blood going to it. So no, the arterioles begin to constrict by the autoregulation, okay? And the arteriovenous ratio, as we've discussed, will be decreased, okay? So this is the acute phase of the disease. Now, let's move on to grade 2 hypertensive retinopathy. So the blood pressure will continue to increase. So what will happen? So there will be more severe narrowing of the arterioles. And there's also a phenomenon which I will discuss right now in a second. And we will see some focal constrictions. So some parts you will see. Let me just get my pen out. Give me a second. Pen. Here we go. So look at what I'm drawing. I know it's not the best drawing. So you'll begin to see some parts constricting from the very high blood pressure, okay? So this is called focal constrictions over here, okay? I don't think it's present in this photo, but in this photo I want to show you other stuff. So the arteriole will continue to narrow. The ratio will be less than 1 to 2. The artery is very small in relation to the vein. Now, we're talking about the size right now, but I want to talk about the location furthermore. So what's actually happening now? In the normal structure, which I will show you a better photo in a second, the artery is above the vein in the retina, okay? So keep that in mind, we'll discuss in a second. And now we have something called a copper and silver wiring. So take a look over here, this part. Now, as you can see, this vessel, I told you in a second that it was transparent and the blood appeared red behind it. Now it appears white, and this is not a normal appearance, so they call it a silver wiring. I'll explain what's happening in a second. Keep in mind, keep this picture in mind, and look at here, over here. We have this silver wiring, and it's very severe, and it's very pronounced over here, okay? So what's the pathophysiology? So this is the chronic phase. Okay, I want you to take it step by step. This is the healthy artery. So with an increase in the blood pressure that we have, what will begin to happen? So we have a muscle layer inside of the arteriole called the media, okay? The tunica media, I believe, yes. So this layer with increased blood pressure, it begins to undergo hypertrophy and hyperplasia, so they increase in number. This is the first phenomenon that occur. And the second one, we have intima. So we have intima, okay, over here. We have the middle layer, which is called the adventitia, and the middle layer called the media. Outer layer is called adventitia, okay? So the intimal layer itself begins to proliferate. Now, take a look at this artery over here with its proliferation and everything that's going on. No, there's severe proliferation, so the artery doesn't become as transparent as it used to be. And when we use an ophthalmoscope, we put light inside of the eye. Now the arteriole, it used to be transparent, and now there will be some deflection of the light, and the artery begins to appear opaque. So we have copper wiring. 1 second. Okay, this is copper wiring over here, as you could see by the arrows, okay? Now it appears like orange or yellowish, you know, the copper of iron, actually like literally the copper of iron. And we have silver, which begins to give like some white color, silver. So which is worse? Well, silver is worse and copper is less severe. So copper, and if the disease progresses, it becomes silver wiring. And an easy way to recall it in our daily lives now, copper as a material itself, it's cheaper than silver, okay? So copper is less severe in comparison to the silver wiring, okay? So keep in mind, these are images that we see, and we report what we see based on grades, yeah? So let's move on to arteriovenous necking. So let's take a look at the normal crossing that occurs over here in the first picture. So what's happening? The artery, the smaller structure, okay, is crossing over the vein. So there is no pinching. Like, I want you to take a look, the vein below it. Now, the vein is below the artery, yes. It's not pinched, and they cross each other normally. Now, what's gonna happen? Let's take a look. Now, if we have an arteriole of this size, it's larger, okay? Not larger in terms of diameter, because I've said there is narrowing, but it's heavier, okay? The arteriole becomes heavier. Now, what's gonna happen? It's going to start putting pressure on the vein. So whenever it crosses it right now, you will start to see that, look at this picture over here, yeah? Now, there is pinching of the venule below it. And in some cases, it starts to deflect, like you start to see an angle where before the vein has an angle, and after the vein, it deflects. It's trying to deflect away from the artery in order to resume its normal blood flow, okay? And keep in mind, this could lead to clots inside of the artery. Yes, it could lead to clots and lead to vascular occlusion. So let's move on to the third grade. So what do we see? So keep in mind, we said grades 3 and 4 are more severe cases, okay, and more acute cases. And keep in mind grade 4 is an emergency. So grade 3 is caused by severe hypertension. So what do we see? Over here we see cotton wool spots. I know you've heard of them if you've heard the diabetic video. So these are the cotton wool spots, which I will explain in a second again. And here we begin to have what's known as the flame-shaped hemorrhage, okay? So these are hemorrhages that begin to occur. So what's the pathophysiology going on? So we have a drawing over here. We have an increased blood vessel. And before I go into the details, it's known as the exudative phase. And the blood-retinal barrier, which I will explain in a second, begins to break down. So taking a look over here, we have a capillary, okay? And an endothelium, and between the endothelial cells you see what's called a blood-retinal barrier. So we don't want any fluids to leak outside of these vessels, because the retina is a very dry place, and if we have any kind of leakage occurring, this will affect the vision, because the main point is for light to enter. Okay, this light requires a clear media and no fluids present except in specific areas, of course, such as the vitreous and aqueous, but any fluids present on the retina will cause affection to the light rays entering, and we don't want that at the retina. So a presence of the blood retinal barrier was a must, okay, to prevent any leakage. Now I want you to imagine a case which we have severe hypertension, okay, and the capillaries are very fragile. Now these are endothelial cells, okay, and the capillary, by the way, if you didn't know, it's one cell thick, so we only have one layer of endothelium. So if you have a very high blood pressure, of course they will be damaged. And if we begin to kill some of the endothelial cells, okay, the blood retinal barrier in these areas will be like detached, and there will be leakage occurring. Now, how does this leakage manifest? First of all, we could have rupture of the vessel or the capillary with extremely high blood pressures. So what will that do? It will cause hemorrhages. So as we've discussed, we have, first of all, flame-shaped hemorrhage. And why is it flame-shaped? Because it follows the pattern of the nerve fiber layer. Now the retina has 10 layers, okay? And one of them is called the nerve fiber layer. So basically, in simple terms, flame-shaped hemorrhage is hemorrhage along the nerve fiber layer, and it requires much more details than that to get an understanding of why it occurs in this layer. But to keep it simple, this is hemorrhage in the nerve fiber layer, okay? And what will that hemorrhage do? It could compress these nerves. I'm telling you, it's called the nerve fiber layer, yeah? And the compression of these nerves will lead to ischemia, and they won't get any blood supply. So it leads to a phenomenon known as the cotton wool spots, because they appear as cotton spots over here. So what is the cause of cotton wool spots? It's caused by ischemia to the nerve fiber layer. So if you make it easy to yourself, we'll start off with hemorrhage, and this hemorrhage causes pressure and ischemia on the nerves, okay? Which leads to cotton wool spots, okay? So you may ask yourself, we discussed in the diabetic videos that we have what's known as hard exudates and other stuff such as microaneurysms and stuff like that. Can they occur in here? Yes, the answer is yes, they can, okay? But we focus on other stuff while we are examining the retina, and we leave the hard exudates mainly to the diabetes, to the diabetic retinopathy, and the microaneurysms as well, okay? So we leave it to them. And although it may occur, it's not the main thing, like it's not the hallmark of the hypertensive retinopathy, of course, okay? We focus more on the arterioles, the copper wiring, the silver wiring, and stuff like that. And moving on to the final grade and the last grade, which is an emergency, we have grade 4, hypertensive retinopathy. So keep in mind, now, its hallmark is bilateral optic nerve edema. So how could edema occur in the optic nerve, and why is it bilateral? So with malignant hypertension, very high blood pressure, okay? So what begins to happen? There is an increase in the intracranial tension, okay? Now this intracranial tension manifests as bilateral optic nerve edema. And not only that, so let me show you a very good image of flame-shaped hemorrhage. So let me just highlight it. So this is what's known as the flame-shaped hemorrhage, which I'm trying to draw from. So here we go. And keep in mind, it's also mixed with cotton wool spots. Now, Grade 4, just because it's grade 4 doesn't mean it only presents with bilateral optic nerve edema. No, you could see, like, look over here. We have here hard exudates. We have cotton wool spots. We have some silver wiring and copper wiring of the vessels. So no, it presents with all of them. I'm sorry, this is an R3. But it presents with the previous grades as well, okay? So, is the patient symptomatic? So, grade 1 and 2 are often asymptomatic because we didn't see any direct affection of the vision, okay? But grades 3 and 4, we're talking about optic nerve edema, we're talking about increased intracranial tension. So no, the patient could have some kind of headache, okay? He could have vomiting, for example. And of course, affection of the optic nerve will lead to decrease in the vision because this is the optic nerve. So no, yes, he could have blurring of the vision. If the macula is affected by the hemorrhage and stuff like that, the vision will be affected. So grades 3 and 4 have changes in the visual field. I'm sorry, the visual acuity of the patient. Okay, management. So how do we manage a patient with hypertensive retinopathy? So it's a very easy answer to this question is that we have to regulate the blood pressure, okay? And maybe he could be given some ACE inhibitors or stuff like that to regulate his blood pressure. And once you regulate his blood pressure, these changes begin to decrease in the retina and it begins to resolve and it prevents any sort of progression. Now, of course, follow-ups are very important because we don't want progression of the disease. And yeah, okay, so if you've made it to the end, thank you for watching this lecture and I'll see you in the next one. Thank you.